Extracorporeal support in the pregnant population. My name is Hayanga from West Virginia University, and I am joined today by...
I'm Nick Teman from the University of Virginia.
Today, we will discuss extracorporeal support in the pregnant patient.
Extracorporeal membrane oxygenation, or ECMO, is a life-saving treatment for refractory respiratory and cardiovascular failure. It has been shown to have favorable outcomes in the H1N1 influenza pandemic, in non-infectious respiratory failure, and the COVID-19 pandemic, as well as several different scenarios of cardiac arrest. However, ECMO may be underutilized in pregnant patients, where pregnancy-related mortality is on the rise. Maternal mortality from severe ARDS or cardiac arrest is associated with mortality rates approaching 40%. Unfortunately, the data for the use of ECMO in pregnant patients is limited to case reports and multi-institutional case series. The purpose of this talk is to discuss the indications and considerations for ECMO in the care of pregnant patients.
The indications for VV and VA ECMO in the pregnant patient are similar in the non-pregnant patient. The EOLIA criteria dictate the use of VV ECMO predicated on levels of hypoxia, hypercapnia, as well as acidemia that is refractory to conventional therapy. VA ECMO is used based on cardiogenic shock and uni or biventricular failure. Of these indications, the effect of maternal amniotic fluid embolism can mimic those of massive pulmonary embolism and drive the need for extracorporeal support in the face of acute shock refractory to pharmacologic hemodynamic agents.
Now, there are several considerations unique to pregnant patients when we think about management of ECMO. And after cannulation, it's important to consider the entire physiology of the patient. First, in all patients, ECMO is dependent on venous drainage from the right side of the heart. However, in pregnant patients, venous return to the heart can be limited due to pressure from the uterus on the inferior vena cava. Placing the patient in the left lateral decubitus position can help relieve this pressure on the IVC and can improve venous drainage and therefore ECMO flow. Second, due to the high cardiac output state associated with pregnancy, higher than normal ECMO flows may be necessary to provide the support needed. This would be respiratory support in the case of veno-venous ECMO, or circulatory support in the case of veno-arterial ECMO. Third, continuous fetal heart rate monitoring is essential, and the maternal fetal medicine team should be closely following the patient in conjunction with the ECMO team. Fourth, it can be difficult or impossible to place pregnant patients in a prone position. Fifth, pregnant patients may be more likely to need blood transfusions due to bleeding complications, as well as the hemodiluting effect of the increased blood volume that's associated with pregnancy. However, centers should still follow their standard transfusion criteria for these patients, as they do for ECMO patients that are not pregnant. Finally, it is important to note that in some cases, it may be necessary to cannulate these patients centrally, particularly if they are in extremis. Peripheral cannulation can be difficult in the pregnant population due to the size of the femoral vessels and their relation to the uterus.
Additionally, one must consider the impact of the combination of agents used in the typical conduct of extracorporeal support and intensive care as a whole. Now, these include sedatives, anticoagulants, neuromuscular blockers, and cardiovascular agents that have to be carefully titrated in the context of dose, duration, and with the utmost consideration of the side effect profile of these drugs, so as to be cognizant of potential effects not only on the mother, but also on the developing child, whose very susceptibility fluctuates with gestational age and the viability of the mother.
The question of when and how to deliver the fetus is very important. But again, there are limited data and limited societal guidelines to guide these decisions. The most important thing is to have a multidisciplinary discussion with input from maternal fetal medicine, heart failure cardiology, cardiac and obstetric anesthesiology, and cardiac surgery. The approach should be tailored to the specific clinical considerations of the mother and the fetus. Delivery can be performed both via vaginal delivery as well as cesarean section, and it can be timed to be performed before or after cannulation for ECMO. Oftentimes, it is appropriate to perform the delivery in an operating room or procedural suite where the anesthesia and ECMO teams can be present and ready to intervene. It's also important to remember that corticosteroids should be administered to the mother when a premature delivery is being considered.
The typical combination of complications specific to ECMO holds true for obstetric patients, and the most lethal is hemorrhage. Also, intraoperatively, during the process of cannulation, hemorrhage is a reality, as well as in the postpartum period, with the additional threat of DIC from retained products of conception that may themselves be masked by hemolysis from the circuit. The other risks of multi-system failure also hold true.
As mentioned earlier, the data for ECMO in pregnant patients is limited to case series and case reports. However, we have still some data to guide our efforts. Dr. Hayanga's group at West Virginia reported excellent survival in ECMO patients who are pregnant. They reported 11 cases with 100% fetal survival and 82.9% maternal survival. There was also a systematic review in the Journal of the American Heart Association that encompassed 221 series and 358 patients. They reported a 30-day maternal survival of 75.4%, a one-year maternal survival of 74.3%, and an overall fetal survival of 64.7%. Another meta-analysis of various case reports showed 91% maternal survival and 79% fetal survival.
In conclusion, ECMO utilization during pregnancy has favorable maternal and fetal outcomes, but it requires an intricate multidisciplinary approach so as to render a most complex algorithm of patient care that affects not just one but two living humans. Further work is required to craft guidelines for cannulation, management, and delivery to better optimize maternal and fetal outcomes in this vulnerable population. Thank you very much.